Yeah, it's
Yeah. Not the
not
associate.
associate?
Yeah,
Just
it's
clinical?
clinical.
Okay. Over here. Hi everyone, we're going to get started. Again, if you could please move into any of the empty seats in the middle and leave some empty spaces on the end so the stragglers who come in will have somewhere to sit. That would be much appreciated. And if someone could please close the doors at the back, that would be great. Yeah, there's a couple of seats at the front over here if you're looking. So it is my great pleasure to introduce to you Dr. Mandy Brisebois, who is a friend and a colleague and clinical professor from the University of Alberta. Mandy is an expert in managing chronic non-cancer illnesses and is going to talk to us today about liver disease. Thanks, Mandy.
Thank you. Okay, my mic, excellent. That's great. This technology is super cool. I haven't been wired up like that in a while, so fantastic. Very, very excited to be here in person, and I've been waiting for this conference for probably 3 years now, 4 years, and I wasn't sure it was going to run this way, so I'm very happy to be here, and I'm seeing people in the audience who I haven't seen or have seen in a while, so thank you all for being here. I remember giving a talk in San Francisco about this probably about 8 years ago, and there was maybe 30 people in the audience. And then I gave that same talk again maybe 5 years ago, and it was full, this huge, huge auditorium. And I look at everybody out here today and I think, wow, like what a difference in chronic illness care and the interest that we have. So I'm very appreciative of all of you here. I did create this slide deck thinking that it might be a bit more interactive. So it will change a little bit. You'll see that there's some questions in between on certain illness states to think about what you've experienced in your practice. And if you're online, if you want to type in questions when I have those slides, or if you're in here, if you want to think at the moment, do I have questions about that specific part of cirrhosis, then we can talk about it at the end of the talk and it'll make it a little bit easier. So I have no conflicts of interest, no huge funding, unfortunately. So learning objectives, I really want to talk about prognostication a bit. And I know that we have people in the audience that are really thinking about palliative medicine. And I want to interrelate this to the specialists we have in our zones, in our cities, and the family physicians that we have, and how they feel comfortable with the work we're doing and how we can integrate. One of my real interests is transitions of care, and the prognostication piece is part of that. I want to show you a website that we've created, so I'm actually going to need some support from the tech people here to click when I ask you to get onto the website, so hopefully that will work, and I can show you a few really interesting things that we're doing. And then I'll give you some updates. This is not a long talk. I give a talk to Portugal University for 6 hours in a row on cirrhosis, so I'm happy to provide those slides as well, but I'm just trying to give an update today on ascites, variceal hemorrhage, encephalopathy, and I talk a little bit about hyponatremia, and then I'll give a couple new pearls about hepatocellular carcinoma treatment. It covers all the CanMeds framework, so that's kind of exciting when I was going through it, but a lot of talks do that. So as high-level practitioners, as I was talking, we really need to pay attention to survival and what it means. And our patients really want to know this in chronic illness. And I've had a lot of conversations with family doctors and my palliative colleagues and internists about whether patients really want to know this, and they do. So this is an article that we published in 2018 on cirrhosis. We're really lucky we had a graphic designer work with us, and we actually had patient forums helping us decide how this graphic should look, and we had some say, no, it has to be black and white, and other cirrhosis patients said it had to be color, but we ended up with color. We actually have pocket cards that have this graphic and the next graphic on it, and I use them to teach patients and residents about when to actually bring these discussions into play with respect to chronic illness care. So when they're diagnosed, it's the very left-hand side here, and all of the green stuff is disease-modifying therapy, the stuff that the hepatologists are going to be doing, trying to help control the disease from progressing. And the orange stuff is all the stuff that we love, the symptom management, integrated care, psychosocial care, the mind, body, spirit, all of these things. They should come into play day one. So I was talking to some of my colleagues today already about the cirrhosis transplant clinic that just starting up in about a week, the first patients will see. So we have a collaboration in Edmonton with liver transplant patients, and I'll be seeing all of the patients that first come to the liver transplant clinic to teach them these principles, and this graphic has been embedded into the materials that they give the patients. So this is a study that we did quite a few years ago. Well, gosh, it seems like quite a few years ago. I think it was 2018, but with the pandemic, it seems like 10 years now. This was for our cirrhosis patients in the cirrhosis clinic. And basically, they said, we want to know about advanced care planning early. We don't want to hear about it in the hospital. And the reason I show this is now 4 years ago. And when I was talking to the cirrhosis patients in the clinic and starting this transplant clinic, they said to me, I'm not really comfortable doing advanced care planning discussions. And this is my high-level colleagues. And I said, well, I understand that. You know, we have a lot of training in palliative medicine to do this. And how do you find it's going? You know, how many patients do you talk to about advanced care planning in your clinic? 0. So this is a high-level cirrhosis clinic where one of their physicians is highly involved and really world-known. So Dr. Tandon, who's my dyad partner, they don't do the conversations. And so I show this because it came out of their clinic, but they're so busy and they don't have time, and it's very difficult to integrate that care. So who does it? So they're very excited to have palliative care involved. They're very excited to have family practitioners involved, but there's lots of evidence in the literature it doesn't have to be physicians who do this care. So we're really hoping to integrate with family physicians doing this care. Can you get nurse practitioners to do these kind of advanced care planning discussions in clinics? And this is the kind of care that I'm promoting. I do a virtual care now in all my chronic illness patients, and advanced care planning is a perfect way to use virtual care because you can have families there, you can show resources online, etc. So it's a great way to do advanced care planning. This is also in that paper, and it's components of advanced care planning, which many of you in the audience will be very familiar with. This is just a graphic we made, and we love the cogwheel. Dr. Tandon and I came up with this when we were driving from a conference in Banff back to Edmonton, and we said it's so fluid. So advanced care planning, if you've heard of serious illness conversations, Dr. Tandon and I had big discussions all the time about this serious illness conversations because it's very regimented. So it's start here, then go here, then use these words, and you can use these words. And so she said to me, I don't really like our wheel. It's too fluid. I'm not sure how to do it. Can you watch me in my clinic? So I went to her clinic and observed her with 5 patients doing advanced care planning. And she came with the first one, and she started with the serious illness conversation. After about a couple minutes, she looks at me and she's like, oh, you could tell she was really disoriented because the patient guided the conversation in a different way. They started talking about maybe prognosis, or they started talking about disease complications, all the little pieces on the wheel. So she underwent 2 conversations, and after the second patient, she said to me, I get it now. She's like, the patients drive the conversation. And I'm an executive and wellness coach, and I did that for my chronic illness patients. And what I found out is they have to lead the conversation, just like your coachees do when you're coaching someone. So this wheel is great because the patient's at the center and their families are there, and you can go back and forth. And this is a big conversation. It's not at night, 2 a.m. And so this is on our pocket card as well with the other graphic. And we explain to patients that these conversations are very complex. So let's talk about liver disease. I obviously can't give you a big dissertation on liver disease. That would also take a very long time. But these are beautiful graphics that came from Dr. Tandon and one of her mentors in the United States. So basically, the liver continues to cirrhose, and people start with a fatty liver, and a lot of people in family medicine clinics now are having fatty liver. So this is very important to recognize early and get the hepatologists involved. So every time I give this talk, I get depressed. So I'm just going to tell you right now, I look at the survival of patients with cirrhosis, and it's honestly dismal. And when they come into the hospital or you see them in your clinic, it is very easy to forget that it is so bad because they look pretty good. I mean, they have big ascites, they may be cachectic, but they're working, they're walking around. So many patients, as they're in the compensated cirrhosis realm, look good. But when you look at a survival of 12 years, if I told you you had 12 years to live right now, it probably wouldn't feel good. So 12 years really isn't that long. And then when you get to decompensated cirrhosis, and that's any one of these problems, then the median survival is 2 years. That is very, very little. When you actually start getting into having more than one of these things, so if you have a hemorrhage or if you have a non-bleeding complication, the death rate starts increasing exponentially. If you have a non-bleeding and a bleeding complication, the 1-year mortality is 57%. That is awful. And I think back to my internal medicine career when I only saw medicine patients on the ward, and I saw so many patients with 2 complications, one bleeding and one non-bleeding, and I did not discuss the prognosis with them and talk to them about it. So it is very, very important. And the critical thing about this data that is not on here, it does not consider their comorbidities. So many of our patients also have vascular disease. They also have some heart disease. They may have diabetes. They may have cholesterol issues. So all of a sudden, this data is completely wrong because it's only considering cirrhosis. So keep that in mind. So once they get these initial complications, great, now they get more complications. And they're very, very sick, as those of you who know these patients are so unwell. So this, I love the triad, the diagnosis, the therapy, and the prognosis. We're pretty good at diagnosis in medicine, and we're really pretty good at doing stuff. It's that prognosis piece and pulling back like we want to do in palliative medicine and really understanding what the patient needs and what they want. So I use that graphic I showed you at the beginning with the graph, and I show patients that. And I say to them, where are you on this graph? Once I've explained it. And they usually, and they're in hospital, and they say, well, last admission I was down there at the bottom of that dip. And I said, well, that's getting close to dying. What did you think? And they said, oh, I was sure I was dying. I'm like, oh, well, what was it like when you got home? Oh, I was way worse. So the patient actually explains the graph to you. You don't have to tell them their prognosis. They tell you. And I ask the patients, how long can your body hold on like this? And they'll usually say, well, I don't know, not long. Or they'll say, I'm doing great. So we all know that our body's connected to our brain. And some people on paper look like they should be dead about 2 years ago. I have a patient that just texted me the other day because I told him he had a couple months to live. This was 1.5 years ago. And he still texts me. I'm like, I love being wrong about that because our bodies are connected, so we're not perfect. So liver disease has some pretty good prognostic tools. Of all the chronic illnesses, it's one of the best. So we have Child-Pugh, we have MELD sodium. As I'll talk, the sodium's been very related to prognosis. CLIF SOFA and CLIF ACLF, they are acute care prognostication tools. So if you're in the ICU, your patients are there, they use those tools to determine prognostication. Interestingly, though, they often don't relay that to the patient. They use it for their own decisions, whether to admit the patient to ICU or not, but they don't actually end up talking about the patient to the patient or the family. Then they go to the ward, and they don't have an understanding that maybe they won't survive if that happens again. This is just an example of the Child-Pugh, and you don't have to read all the little minutia on there, but I really want to point out the survival on the right-hand corner at the bottom. So 2-year survival if you have well-compensated disease is fine, but 35% if you have decompensated disease, that's one of those complications. This is not good. MELD sodium, they've added this, and this is how they're determining survival for transplants. So if you're looking at transplant, and transplant is a whole nother talk because people have to get now in Canada, and it's different in Canada and the US, but in Canada you have to have a certain MELD score to even qualify, and it's bad. And so a lot of the patients in my clinic would say, I feel good, why can't I be on the list now? Because I'll survive the surgery now. Well, it doesn't work that way. You have to be really sick before you get on the transplant list because of the limited number of organs. So this is a lot of psychosocial distress that comes for patients. And again, the mortality with MELD scores as they increase, if you have a MELD score of 40, which is very poor, there's a 71% mortality in 3 months. Okay, so these things are very important to know about. The palliative performance score that many of us are familiar with in palliative medicine, how we can function, and I use this in chronic illness all the time, it is the number one thing that I explain to patients. If you're seeing a deterioration in function, and most of you here will know this, that it is not good. Now, I always say, how were you compared to last month? And how were you compared to the month before? And if they're saying, I'm getting worse, well, all of these numbers to me mean nothing. And many of you will have heard, if you're deteriorating year to year, you have years to live. If you're deteriorating from month to month, you have months to live. If every week you see worse, you have weeks and days, you only have days to live. I swear that's the best way to look at things. And the patients say, oh, it's weeks. Oh, so if you're deteriorating weeks to weeks, how fast? How are you going to be in 5 weeks? And they're like, not here. And honestly, this is what patients say. So they're very, very smart about their function. They see it. So I want to talk about symptoms in cirrhosis care. So symptoms, now can you click on this link for the cirrhosis care website? So I'll talk a little bit about the ESAS, as many of you know, while you're working on that. Just click on the cirrhosiscare.ca on the thing. It should just, there we go, make that big. So, and if you can click the healthcare professional resources up at the top, underneath cirrhosiscare.ca at the left, cirrhosiscare.ca, move your cursor over the other side. Now go down. Down one more. And go to healthcare professionals. I'll just show you a bit because you guys can cruise this on your own since I don't have ultimate control. But we created this website with Dr. Townsend, and I came up with this concept. And we have, oh my goodness, the number of physicians that are involved in this. Physicians, social workers, psychologists, physiotherapists, nutritionists, like the list is massive. So if you want to go to this website, you will get all of the resources that you need. It has about medications. It has patient education. It has videos about paracentesis, what it means. What are you going to do if you get one? What are the complications? So here you can see prescribe education, symptom management. We've gone through with multiple health professionals and gone through all of the literature with symptom management. So I don't have to do it here, but I will tell you something that is very, very important. I have sat on a lot of committees in my life to create papers and guidelines, and you'll read about lots of guidelines about symptom management in cirrhosis and other chronic illnesses. Almost always, these are consensus statements. So they're not randomized controlled trials. A bunch of us are sitting in a room debating about what we should put. And I can tell you this website, we debated hard about a lot of stuff. And the problem is that because it's not in the literature, so some random person wrote an article saying use 0.5 of hydromorphone, so now that's okay. And so we thought about this because it says in here, these are the guidelines, these are the basics. But I don't actually do that in practice. So this is really important to realize. I use less. And they said, so for example, for pain, hydromorphone 0.5 milligrams, because it's the smallest I can cut, is what's recommended. But if I have a really sick cirrhosis patient, I will turn it into a liquefied hydromorphone and use 0.2 milligrams under the tongue or subcutaneous. So what I say to people, and we actually have disclaimers in this about it, that much of the medication, as you all know, in palliative medicine is off-label, and that needs to be disclosed to the patient. So for example, Haldol for anxiety is off-label. And so that has to be disclosed that, hey, we're using this, we know what we're doing, we know what the medication can do. So it's very important to know that. And I'll show you some other resources. You can get off of this now. Thank you. So the ESAS we've revised a little bit. This is the score that goes from 1 to 10 for 10 different symptoms. We put muscle cramps, pruritus on there. Those are fairly common symptoms as well, but very, very difficult to treat. So many, many patients with cirrhosis have pain. It's probably the biggest symptom that I had to deal with patients in the clinics, mostly abdominal pain from significant ascites, back pain from the burden of having the ascites in there. And ascites control usually does significantly help the pain. Lots of anxiety and depression. And one of the biggest things was being on a transplant list. Very, very tough for mental health. And also body habitus change. So that was one that I wasn't expecting as much, and no gender specificity to that. So men, women, can't fit in their clothes anymore, can't wear shoes, just feeling very dysmorphic from what they previously were before they had ascites in their abdomen. So the quality of life score is not good. Okay, lots of psychological stress. And the families many, many times needed to have conversations outside of the room from the patients. And this is where virtual care has been fabulous. So I can meet with a family and talk to them. Let's say the patient doesn't want to know about all the complications in the future, because I offer that to them. But they don't want to know if they have black stools, that they're bleeding. They want to know if they start throwing up blood, they have to go to the hospital right away. But the family sure do. So they want to know what to watch for. So in cirrhosis care and a lot of chronic illnesses, I'll have separate conversations depending on what the families need and what the patient needs. And of course, that's with the patient permission. Usually they're very happy to have their families talk separately and be prepared if they don't want to be themselves. Many patients do, though. I had one patient with liver disease, and I'll just say this because it's very interesting. It was actually a colleague of mine, very, very smart physician. And it was her dad who had liver disease. And she's like, what do I watch for? And what do I do? And I talked to her about bleeding and blood per rectum and vomiting blood. And she said, this sucks. And she's an emergency doctor. She said, this is really scary. I hate this. I don't want to know about it. She was actually a little irritated. But I sent her home with tranexamic acid, which interestingly doesn't work, but I'll talk to you about that. This was about 8 years ago. With tranexamic acid, we had a plan. She had red towels right next to in the bathroom. Her dad knew, and I said, hey, I talked to him and I said, hey, if it looks like a ton of blood, it's not really as bad because it goes in the water just a little bit. Don't worry about it. Anyway, he ended up pooping out a huge bucket of blood. And she said, okay, Dad, Amanda said that you just get back into bed and you'll be fine. And so he did. And she gave him the tranexamic acid. She cleaned it up. And it ended up stopping. He lived probably a couple more weeks after that. But it was so interesting because he wasn't stressed, because he had had that precursor explanation. And can you imagine if you poop out a bunch of blood and you're looking in the toilet, you could panic. So she said to me after, that was such a lifesaver. And here it was from someone who was so smart. Oh, I missed that slide. But most of you understand this as I was talking about this total pain. It is very prominent in cirrhosis patients because many of them have long histories, addictions, and if they have alcoholic cirrhosis, that can be a big issue and it needs to be addressed while they're going through their illness. So cirrhosis, when I first started seeing the patients, I prescribed quite a few medications. And now I provide almost none. So I really transitioned from giving opioids and giving anxiety medications and all of these things to really following what the pain clinics are doing. Non-pharmacological therapy is the answer. And patients don't always like that right off the bat, but I just tell them this, I show them this, I say this is where it's at. I have multiple sclerosis, I will disclose. I live with chronic pain. And I actually sometimes disclose that to my patients. I say, you know what? Sometimes it does suck, but you do have to learn how to incorporate symptoms into your life and make your life great. Because as I'll tell you, the medications won't necessarily make your life great. And what I found is when I give them the medication, they're happy the first visit. I felt like an amazing doctor. All their scores dropped. I'm like, I'm a winner. And then they came back the next couple of visits, and all of a sudden, I'm not a winner anymore because they're not doing well. Because the medications gave that initial, I'm doing better, but then they fell right back into how do I deal with chronic illness and all the other pieces. So liver metabolism, you don't have to read this whole slide, but I want to just show you there are a lot of things about liver metabolism that if you're prescribing in liver disease, you must look up every single medication. So every single medication may be impacted by liver metabolism, and if it's not, it may impact another medication that the patient's taking. So very important. This is an amazing website, which I wanted to show you, but can you click on that bottom box? I like that, he woke him up over there. He doesn't find cirrhosis interesting. This is really a great website. I just want to click on it so that you can see. You can click, when you go to this website, any medication. So it's liver tox, and it has right there, search in this book. And you can search any medication. Can you type, oh, this is going to be interesting. Can you type in, no, on that box that you're at, can you type in aspirin? I'm trying to pick something that you will definitely know how to spell, but we'll see. I was going to pick bisoprolol, but that probably wouldn't have gone over well. No, it didn't actually. No, that's the wrong place to to type, sorry. Go back. The box right to the bottom, go down by the book. It says search this book. Yes, no, go up. Oh my goodness. Okay, regardless, if you're on that website, just forget it. We're moving on. If you go to that website, if you go to search that book, you can type in any medication and it comes up, aspirin, click on aspirin now. It'll show every single detail, all the COX ways metabolize that are being impacted. I remember I was talking to a pharmacist. See, look this, impacted by COX-1 and 2, blah, blah, blah. If you're using medications on liver disease and something's not working, this is the key point. Something is not working, you want to pick another anxiety medication. Go here and pick one that is using a different COX system. That is critical because there's multiple of them, and if you pick the same one, it's very likely it also will not work. Okay, so pick something. This website is great for that. You can just, even if you have no idea, I don't remember all of the systems. I don't have that much brain power. But if you know that you have to pick something that's working differently, that's the key with progression of medications in liver disease or really anything that's being metabolized by the liver. So thank you. You can get off of that now. But it's got lots of great information, as you can see. Clicky, clicky. This book is fabulous. So if anyone's seeing mainly cirrhosis patients, it's new. It was printed in 2020. Most of the stuff that I'm giving you about updates is from there, plus some articles, and excellent dissertation, really, on how to manage chronically ill. So we all know what ascites looks like. Big belly full of fluid. So with these symptoms, I'm just going to give you some updates, okay, some clinical pearls, and then you can ask questions after. So we've had a discussion for a lot of years about large volume paracentesis, indwelling catheters, and diuretic therapy. So there's been shown to be no survival advantage comparing paracentesis to diuretics. So that's interesting. So you're not helping your patients survive longer, you're helping them feel better. All right. It's also been shown not to remove more than 4 liters a week. Now, in medicine, even fairly recently, I would remove more than that for comfort. But it really does affect the sodium in the kidney. So the patients need to be aware of that, and they need to understand that they're sacrificing potential longevity for comfort. This is refractory ascites, so that you know the doses of the spironolactone at 400 and Lasix at 160. If you're not losing weight, you're diuretic, you're resistant. Only about 10% of patients are diuretic resistant. Usually we are not at the right dose. Okay, so people will stop a bit early and think that they're diuretic resistant. So don't stop early. You're intractable when your creatinine, your kidney function starts to deteriorate and the sodium goes down. That's when you're starting to really run into trouble. Okay. So when do you get a paracentesis? When they're clinically poor. If it's within their goals of care, always thinking, do they want to have this done or not? Because I don't stick needles into people. I had someone die of a paracentesis once. They went a little too medial, hit the epigastric artery, and the patient bled to death. So they're not innocuous procedures. So patients need to know that as well. The big one here to really take notice of is GI bleeding. Any GI bleed, if they have ascites, do a paracentesis. Infection goes along with the bleeding. So make sure you remember that. Okay. And if you're trying to manage symptoms as well. So the survival is dismal for refractory ascites. 6 months survival of 50%, 1 year of 25%. The number of patients that I found with that, who I didn't tell that, in my previous life, is many. Okay. I mean, it's hard to talk to them about these things, but they need it, and usually the hepatologists haven't. So the poor survival factors are low protein in the acidic fluid, the higher MELD and child Pew scores, bacterial peritonitis, and if they're still drinking. Okay, that still drinking is a really tough one. So I do a lot of small volume paracentesis in my palliative medicine practice. So and I'll talk a bit about indwelling catheters, but when I have indwelling catheters, I'll do, take 500 milliliters off a day, just take the pressure off. The patients love it. It does have less hemodynamic change. There is no evidence to support my practice. So this is, again, off-label. But if they're not tolerating those big volumes and you want to try to preserve a little bit of that and not affect their kidney, or if they're hyponatremic, then that's actually a good approach. And they can do that at home. And they really are in control of their body, which is very useful for people to feel that they have control. So albumin replacement, here we go. Here's another one. So I see this all the time still on the wards. There is no benefit, and this has been shown in studies, to give albumin to increase the serum albumin. Okay, so if you're just doing it for that reason, don't do it. But if you're taking out more than 5 liters of ascites, do it. And I actually, in palliative medicine, hadn't been doing this until quite recently, actually, because I wanted to preserve product. I was trying to be economically responsible, try to save the product. I didn't think it necessarily helped the patient. But if they do have weeks to months left to live, it will impact their body, their volume, their sodium, their albumin, etc. So it is a good idea to do. So we do recommend doing that when you're taking more than 5 liters off. Antibiotics, again, prophylaxis if you have a GI bleed, if you have a low albumin in the ascites, and also if you have SBP. I do more antibiotic in my palliative patients than I used to. I used to be not much on it. I used to not think if you had a bleed, I would give them, but it helps their symptoms. And so, I think if they have a significant amount of time left, meaning even weeks, if I can prevent discomfort and belly pain by giving them the antibiotic prophylaxis, there is evidence to do that. This is a really nice current review. I tried to pull up some good current reviews for you to take a peek at if you want. This is August 2022, talking about refractory ascites. It's a great systematic review. So look this up if you're interested. There's also a really cool thing coming up called uncuffed catheters that radiology can put in. They usually put in tunneled line and pop a balloon up. These ones don't have a balloon. They have fewer complications, they come out easier, etc. So there's a lot of neat things that are coming on for people in palliative medicine who want to take care of their patients in the community. This is a cool thing. Who here, anyone from the US? So in the US, I'm not sure if you have alpha pump. Here we don't have as much access to alpha pumps. They're quite expensive, but many places that I've spoken in the US have them. They're little tunneled pumps that pump the ascites out into the bladder. Super cool. Yeah, I know. Whoa, I love that. I wish I had that on video. Very, very cool idea. I don't know who came up with it. When I first started giving these talks now with the alpha pump, maybe 5 years ago, 6 years ago, there wasn't a lot of evidence whether it was good or bad. Now there is evidence that there is more likely to have acute kidney injury. So 30% develop acute kidney injury, and infections are quite prominent, which is interesting. But still, if I was a patient, I think I might go to the US and buy one, because they're pretty cool that they just go out that way. You don't have to have these bags, etc. So this is a study that was done in 2022 as well, looking at the tips. So PVS is a peritoneal venous shunt. They put a little catheter in. They have a little latch here. One goes into the fluid and the other goes into the venous system. So it's basically pumping the ascites back into the venous system. Then the tips is where they're bypassing the liver. LVP is large volume paracentesis, the alpha pump, and MIPCC is the indwelling peritoneal catheter that we know of that sits in there. Now, the thing with this study is the mortality for the MIPCC was higher, quite a bit higher than the other ones, but they were mostly inserted for patients at end of life. So I do think this has nothing to do as much with the technique as when it's being used. And I can say too, that's when I mostly use those, is if they want to be at home, they don't want to come in and out and get these intermittent large volume paracentesis. At our site, the hepatologists are all using the large volume paracentesis for their patients. They are not putting in the catheters unless they are end of life. They still believe that the infection rate is higher, although there is currently no evidence of such. And I remember, I went backwards. I remember having a conversation with Dr. Tandon, actually. We were arguing because I loved the indwelling catheters and she loved the large volume. So I had a patient and I said, well, I'm going to show you, I will do this on this patient. He had no end of trouble with the indwelling catheter. Leakage, drainage, infection, had to re-put it in. It was awful. And so I just thought, because I was trying to prove a point, that happened. But it does happen. So you just have to be aware. And as long as the patients are aware of what can happen, you can't really run into trouble. So hyponatremia and hypotension, here's another good recent study, a couple of years old, that when you're doing these drainage, and this one was for a malignant ascites, but same goes for your patients with cirrhosis, you are more likely to get hyponatremic. So keep that in mind, because hyponatremia definitely contributes to hepatic encephalopathy. So that's something that you really have to think about. We don't do much about hyponatremia sometimes on the palliative wards. I think we need to pay more attention to it. So many, many patients are getting more hyponatremia. So if you have a patient with hyponatremia before the large volume paracentesis, make sure that you're thinking about it. This is when I love those smaller volumes. So if you have someone who's running in trouble, I'll talk to them about this and say, if we put in an indwelling catheter that's sitting there, you can take a liter out at a time, much less likely to have problems with your sodium, and I found it very effective. So this is very interesting. If you take 2 liters of ascites out, that equals the sodium of a daily diet. So you're basically taking all the salt from their body that you would normally eat in a day. So that really shows you why you run into trouble. So I actually sometimes I love salt tablets. So someone, again, off-label, so we don't have evidence that salt tablets helps hyponatremia. But when I have someone with a sodium of 120 and cirrhosis and little tiny volumes aren't working, salt tablets are fantastic. So they can put salt on their food, but the salt tablets have so much more salt. We'll use that. And they have different doses depending on where you are, so you just have to ask the pharmacist. So tips about hyponatremia, very important to know that you can replace your volume you take out with IV normal saline, something that's isotonic, or albumin. That helps. Or you can administer crystalloid continuously. Now, for years, I told patients that giving them volume goes immediately into their abdomen. So I'm like, oh, we've got to stop the fluids. You've got the belly that's super tense. But this study came out that it doesn't actually impact that. And so that's something that I actually am going to change, telling my patients from researching for this talk. So that's very interesting. So other tips, as I said, you can restore the sodium level usually, but if you can't, you can replace with sodium losses IV fluid, or you can give salt tablets. And you can tell them just don't drink, tons of water, etc., and increase dietary salt. Okay, so this is where I was going to ask people for questions about ascites. We won't do that now. We can do that later. Think if you have any patient cases, you can type them in the chat, etc. So let's talk about variceal hemorrhage. My first patient as a medical student who died was a patient with cirrhosis, and I was a naive medical student sitting by his bedside. Just talking about it brings up trauma. He vomited blood for half an hour, and then he died holding my hand, and I sat there. And it was awful. I was on an internal medicine ward, and nobody mentioned palliative care. Okay, I'm old, so we've progressed a lot since then, but nobody mentioned it. No one thought about giving him pain medications, anxiety medications, sedation, nothing. So he threw up blood until he died. So it really can be a tough thing that we, as we all know, we have to think about. The mortality from variceal hemorrhage is huge. 10 to 20% in 6 weeks, 30 to 60% in 1 year after one bleed. Okay, so that's a really big deal. And if you've had a second, so if your variceal hemorrhage is a second event, so you had ascites first or encephalopathy first, the death rate increases to 88%. And remember, this is not including any other comorbidities, including frailty. And we'll talk about frailty. But how many of our patients are cachectic? All of them. So even if they look huge, they have no muscle mass. So I really think we're under-predicting how terrible these things are. So we really know that treating variceal hemorrhage and decreasing portal hypertension is fabulous and effective. If you're untreated, you're going to have a rebleed, 60%. So very, very important. 30% of those who have treatments that lower this portal blood pressure still have bleeding. Okay, so lowering the blood pressure does not mean that you are, not the blood pressure, but the portal pressure does not mean that you won't have a rebleed. So it's really important to educate your patients about bleeding, about black stools. And I'm always carrying something black, like look, I'm like, oh, black, like really black. So they really know what bleeding is so that they can be seen immediately. So propranolol and lanolol, these are the doses. So you want to get them to the highest dose that they can tolerate. Really important that they're on these medications. This is another cool thing. Now, there was a trial done years and years ago now that I used to promote called the TRICK trial. It was a trial in ICU patients on transfusions. And it basically transfused people aggressively to above 90 and very, very non-aggressively to around 70. And they wished on retrospect they had gone below because the patients that were at 70 did much better as far as survival than the ones they transfused to 90. They've also showed this in cardiac transplant patients and cardiac ICU. Very interesting. This study now has come out in cirrhosis, that the restrictive strategy to keep the blood at 70 is better than 90. So really important. In those other trials, they thought that the viscosity was less, and so that they could, carry fluid better, et cetera. And maybe with cirrhosis, that's similar because their volume of distribution is so off because they have this abdomen full of fluid. So variceal hemorrhages, as I said, bacterial infections are very common. Antibiotic prophylaxis is very important. So make sure that you're doing that or that you're aware that that needs to be done. A lot of times we're consulting on these patients and that's already done for us. But it's good to recognize why it's there. Also, antibiotic prophylaxis is associated with a marked mortality in patients who have high child-Pugh. Beta blockers, if you stop your beta blockers, you're going to do worse. And I used to leave, in fact, still in palliative medicine, I leave beta blockers on till my last moment. I always say once the patients can't take meds anymore, I stop it. Or if they're not standing up or whatever. But beta blockers are very good. I don't want my patient to die of a GI bleed. I don't want them to experience what I experienced and what my first patient experienced. If you can prevent that, amazing. If they start to have side effects, obviously then you have to stop it. If they start to get dizzy when they stand up, that's a big one. You don't want them to fall. So definitely use it and use it to prevent bacterial infections as well as bleeds. So I keep the beta blockers going as long as I can. And cardiac disease as well. So variceal hemorrhage, again, if you have questions, think about them and we'll talk about them later. So hepatic encephalopathy, almost all your patients who have cirrhosis are going to have hepatic encephalopathy. It can be covert, as we call it. I don't know if anyone's seen the DOT test, but it's a godsend. So all you do is you take a piece of paper and you ram like 20 different dots on the paper, and you number them from 1 to 20, and you photocopy it 50 times. So I had this in my clinic. So they come in, and you just say, connect 1 to 20. So they have to go 1, 2, 3, and they're all over because you've just done it randomly. 1, 2, 3, 4, whatever, and you get a baseline, and sometimes it's terrible. So your baseline's terrible. But it is a really great way to follow your patients on the wards and in your clinic with hepatic encephalopathy. It's super simple. If they're even mildly impaired, they struggle. And it's the journey, not necessarily whether they get the line. It's just like when you're completing an MMSE or, these tests for cognitive ability. It's the struggle of being able to do it. So that's a fabulous test. It's called the DOT test, I think. So many of them have covert hepatic encephalopathy. Ammonia levels, don't bother unless you want to show that it's normal and it's not the liver causing problems. So following an ammonia level is not useful. So if it's high and then you think they're better, you check it again, it's lower, that is not useful. Okay, so you don't need to check it again. I have my hepatologist cursing every time they come to the medicine ward and they see ammonia every day. It drives them up the wall. But you can use it if someone comes in with cirrhosis who's really sick and you want to rule out hepatic encephalopathy and it's totally normal. So that's where that's useful. And obviously, there's a lot of precipitants for hepatic encephalopathy. When I first started seeing cirrhosis patients from my colleagues around 2012 or 2011, it might have been, I remember sending a patient back to her and she called me angry. She was irate, actually. A good friend of mine. Why are you recommending that your patients get polyethylene glycol? So Restorelax or PEG. They need to take lactulose. This is horrible. And I was like, no, you don't understand. They refused to take the lactulose. And I said, if you can't take the lactulose, you could at least try this other one. And she's like, okay, fine. So we had a conversation. It was all good. Now there's evidence that polyethylene glycol is just as good as lactulose to decrease encephalopathy. So you can use both. You'll see the hepatologists still want to use the lactulose. A lot of my palliative care colleagues think lactulose is the devil. I like it. I think it works fine. Just depends on what your patient likes the best. I mean, you can get a little bit of nausea from it, but it's totally fine. Another great article, 2020. So it talks about hepatic encephalopathy in patients. So this is a really good review article if you ever want to take a peek and see what's updated. I obviously can't give you it all here. So usually there's a precipitating cause, really important to think about, and infections, bleeding, medication, and electrolyte imbalances. But I thought this is interesting because 43% is infection. Do those paracentesis. Okay, make sure you get those done. And we have really cool little ultrasounds now, like in our community care. Our community care team carries around an ultrasound. We're lucky we have an ex-radiologist who works in our department, so she's leading that kind of thing. But you can actually take an ultrasound in the community and put a tiny needle into the abdomen and get a sample, and that's all you need. So you don't need to do a huge, large volume paracentesis to get that done. And so most common cause of death for these patients is decompensated chronic liver disease, which makes sense, but also sepsis. And again, very poor survival. As I was saying, you're going to be depressed by the time you get out of here. But you'll also be able to help your patients have hope. I really, my patients, and I'm sure yours as well, feel hope when you share with them this information. I was in a room once with a student and a resident and myself. And the daughter and the patient were there. The patient had cirrhosis, and they had no idea what was happening. And we sat down and we told him, asked him what was happening, and he was talking about dying, and we were telling him he probably has days left to live. I mean, this is dismal. And I went in the next morning with the trainees, and the trainees come in, and they're looking and they're expecting this really sad conversation. And the daughter is joyous. She's jubilant. She's like, hi. She gave me a big hug. The patient was smiling, and the student's like, what's happening? And the patient said, I feel so alive. I feel so empowered. Like they could tell their family what was happening. The patient knew what was happening. The patient knew he was dying. But he could talk to his family in the right language, and he saw the joy, the lack of the struggle in his daughter's eyes, and it gave them so much faith that they were going to be okay. So it's amazing how these difficult conversations can turn great. So rifaximin, amazing, use it. So this I keep on till the last breath as well. It is very good. You can prevent hepatic encephalopathy, and fabulous for preventing hospitalizations as well. If you make sure you use it. I remember when we couldn't get it for our patients, and now you can, and it's standard. So please make sure that your patients are on that. Again, encephalopathy cases, love to hear them. Think about any questions you have about that. And so the last thing that I'm going to talk about, we'll have lots of time for questions, is hepatocellular carcinoma. Really, obviously, very common. So when you have a liver patient in a liver clinic, they are going to be followed very, very closely for hepatocellular carcinoma. There are extensive screening protocols that they follow, about 3% per year. It is extremely common, 800,000 deaths per year. That's a lot. They get pain, early satiety, jaundice, They screen with ultrasounds, CTs. Now they have high-resolution CT scans. In some places they'll do that. AFPs. I don't think that if you unless you're in a smaller community, et cetera, and your patients don't have a hepatologist, but there's lots of guidelines out there on how to do this. The survival, again, is not good. So I've had patients come onto the medicine ward that have a hepatocellular carcinoma, and people just kind of don't say much about it. They come in, they manage their hepatic encephalopathy, et cetera, but don't take that into consideration. So if the survival is 6 to 20 months and you have cirrhosis and maybe you have diabetes or whatever it is, you don't have that long to live. So these things are really important. I would say to the palliative crowd that when you are on your medicine wards or wherever you are at, if you see a liver patient and they have not had all of these palliative conversations, they need to have them. And we tried in the cirrhosis clinic, and this is our plan after we do our transplant clinic initiative. The reason we're being so methodical about it is we don't have the evidence yet of how to do it. What is the evidence to combine a palliative physician and non-palliative physicians in a clinic, in a chronic illness clinic, and does it work? So we're trying to develop this. There's a massive study going on in the USA, which is going to be amazing when it's published. And what they have is they've educated hepatologists to do the palliative training, and they're comparing it to palliative physicians. So this should be coming out in the next year or so, and we'll be able to see, can trained specialists do the same work as palliative medicine? I'm hoping they can, because they're trained in exactly what we do in the clinic. So they're very smart. We should be able to get that combination of expertise. So that should come out in the next year or so. Once we get our clinic up and running, we will publish that, and it will show exactly how we did it. You know, these are the people we involved. These are all the scores that we got. This is how we involve the family. It's all virtual. So hoping that this kind of care can be very amenable to virtual care and that we can follow patients this way. So it'll be very interesting, and I hope that we can get some feedback out to you. So hepatocellular carcinoma is the sixth most frequent cancer. This is really interesting. It's much higher than I would have thought. So again, I feel bad, but the survival rate isn't very good. So if it's distance, 3% 5-year survival. So very poor. There's more treatments now. I love all this immunotherapy that's coming out with cancers that we're treating. It's very interesting, much easier to take. And so prior to immunotherapy, I'm going to pronounce this wrong, but sorafenib is the medication that they were using. It doesn't work. So that doesn't work for hepatocellular carcinoma. It's been shown to have minimal benefit. So these immunotherapies that they're now using, they're available. They are limited by some side effects. And the answer is not out yet, whether these are going to be worthy. So here's a really nice new review. It just came out, so 2022. If you're working a lot with cancer patients in cancer clinics with specifically hepatocellular carcinoma, this talks about all of the immune modulators. What ones they have available, what you might be able to get, et cetera, and what the side effects are. So excellent review article. So here's just some of the ones that are available that they're recommending, and the combination with these two, they're recommending as first-line treatment now, and they've shown a survival benefit. So that's good. They compared it to the sorafenib. These adverse reactions, skin rash, fatigue, diarrhea, thyroid dysfunction, and liver dysfunction. So obviously you have to keep a very close eye on that, but very, very useful. So survival may not be improved if it's non-viral cirrhosis, or non-viral cirrhosis causing the hepatocellular carcinoma. So that is very interesting as well. So you have to look at why the cirrhosis was there to begin with. So other complications, we mentioned a little bit. There are a lot of other ones. And if you look at the website, every single complication and symptom we have guidelines for. As I said, you could research those guidelines and you're going to come up with something else in a lot of cases, but they will be consensus-based. So what I always say is you must look at your patient. Your patient's going to tell you what works and what's not working for you. So that's very important. So nutrition is really, really important. You get these anemias, the coagulopathies, thrombocytopenias, thromboses. There are so many complications that you can get. All of those guidelines are on the website. Okay. And think when you think about these complications, I've given you the prognostication for the big complications. What happens when their platelets are 50, 40, 30? They also have albumin of 15. So they also have a hepatic hydrothorax. It's not going to be good. So I actually share this stuff with patients if they're interested, but I don't say it quite the same I say to you. And I will say something. Actually, while I look out here. I was sitting in an audience once. I've had several malignancies myself, and I was listening about a cancer talk about the malignancy I had had. And they kept saying things like, I'm saying right now to you. And I thought, wow, this sucks. So if any of you have cirrhosis or have family members with cirrhosis, in all honesty, so these numbers are about technical numbers. Okay, and so this is when you're talking to our patients, that technical numbers are not you. And when you have cirrhosis, your whole body is in it, just like with chronic illness. And I say to people, that you are not a number, and you're here right now, and I'm here right now, and all I have is right today. That's all I have. So do they. And even if their prognosis is dismal, why I'm giving my career and life to chronic illness care is I believe that you can have an amazing life with a prognosis of 30% in 5 years. Because you can live your life. You're here, you can live it well, you can manage your symptoms, you get palliative medicine around you, you hear the right messaging, you believe in what you can achieve in that amount of time, what you can achieve with that mobility. So that's something that's really important to hear. And so for those of you in the room that may have people you know with cirrhosis, I apologize. But because it is hard, actually, to be in a room. We never think about that as presenters or people attending conferences as well. So hepatic hydrothorax, I've seen quite a bit of it, although it's not reportedly that common. Most of the time on the right, but you can get on the other side. It's transudative. I really, really make sure that that's what it's from. So I always will do a thoracentesis. Always check and make sure that it's transudative. Make sure that I've picked up empyemas, actually, in people that had assumed it was just a hydrothorax. So don't make assumptions, and make sure it's not heart failure, etc. It would be very unusual to have a one-sided one with heart failure, but you just make sure you tick off your boxes. Malnutrition is extremely common. So Dr. Tandon, who I work with, this is one of her specialties. She has tons of papers written in this area. But the key thing that I like in my patients and in the hospital, etc., which makes it hard in the hospital, is this one. The little meals. So in hospital, they get the big chonky meals. That's not so good for cirrhosis. So if they happen to have anyone around them that can bring little meals, and that high protein bedtime snack is critical. So I even write it on the orders. Give them an egg or give them whatever it is, high protein, and if the hospital can't do it, get the family to do something. So something that's really good before bed is really important for these patients, and that's been shown. Frailty, as I said, extremely important. Lots of articles on this. We gave a talk with Jennifer Lay in the US at the San Francisco conference. She's fabulous, doing tons of work in this area. Okay. So it's very good to do some tests on your patients with this, even if it's a grip test, if you have physiotherapists around, excellent to do the frailty index to make sure, see where they are. A frailty of 9, which is low. Frailty in its own is a MELD score, adding 9 points to your MELD score. That's huge. So you think of the MELD, if you forget the frailty, then you're subtracting 9 points. And that's a big difference for mortality. And so then we talk, well, why isn't that part of the transplant assessment? Why don't they add 9 points? They don't, but why don't they? So we've had these discussions in the transplant world. But it's very difficult because they have a lot of people on the list. Some people aren't going to get on the list. In fact, one of the reasons I'm there is because many people are going to die on the list. And so people get delisted, and this is common. So this is the last slide. I'm not going to show you this because I probably can't. Well, maybe. Let's click on one of those links at the bottom. So on the palliative care, we're in Alberta and we're way behind the US. So if you're in the US, you're going to just shame us with your technology. But in Alberta, we have just gone province-wide with Connect Care, which is Epic. So it's a system. We have order sets for everything. So if you go on to the cirrhosiscare.ca, there are 20 or more order sets related to cirrhosis. And they have this one, and you can't, it's too small, if you can increase it. But it has pre-paracentesis, it has admission orders, discharge orders, tons of different things, nutrition orders, all for cirrhosis care. So it's an excellent resource. Again, if you're in a community and you're admitting patients and you're not sure what a specialist would do at the University of Alberta, you can just look on here, and they've used experts all across the country to develop the order sets. So those are very useful. And that, I can't click off that, please, is the end. Black. Am I off? As they say, Operation Over. It's over. Anesthesia turns off the gas. So I would love to answer questions. I would love to hear stories about what people have experienced with cirrhosis care. Does this resonate with you? Does it not resonate with you? I'm a very open person. I love controversy. I love controversial questions. I won't be offended. I see already.
It seems that every GI patient, every cirrhosis patient is on a proton pump inhibitor, and I saw you kind of zip through there, but it's not necessarily a good thing. Could you explain that, please?
Yeah, I'm very anti-proton pump inhibitor these days. In fact, at our site, we're doing a study right now on proton pump inhibitors, but they increase pneumonias, number one. They can increase infection, so you increase your ascites, etc. So if they haven't had a recent bleed and on it for that reason, I get them off. I don't like them. So many patients are on them, and they're bonded to them. So that's a problem. But you can always call the GI docs and say, hey, if you want a backup for your patient, say, I'm just confirming that I can take this thing off. Maybe they had a bleed 10 years ago, or maybe it's just on for some reflux, they thought, but actually it's because they have a belly full of ascites that they've got some reflux. So yeah, I get people off of the proton pumpers.
I'm going to move to an online one, then you can come up, Mino, in the meantime. Are there guidelines regarding peritoneal catheters for ascites management?
Nope. So
Quick one. So you're up now.
well, no, I will say something about that. The guidelines are, what does your patient want? And if your patient, so it's a conversation with talking about what's out there as far as evidence, that we don't really have it, that there's risks of both, large volume paracentesis and inserting a catheter. What are they? You know, what can happen? What cannot happen? And your patient makes a decision. And my patients will make the decision. And then they know that it's been their decision. So that my guideline is what the patient wants. But no, there's nothing. But there are guidelines on how to put them in, how long they should be in, what to watch for with respect to infection, who puts them in. So it's very variable. That you can get radiology, you can do them yourself. Like there's lots of different ways. So that review article will help.
Mino.
Thank you. Thank you, Dr. Brisebois. It was a great talk. I have two questions, one technical and one sort of controversial maybe, or more reflective. Technical question, when you do a catheter, what do you do with the diuretics? Do you just reduce them?
I get rid of them.
Stop them? Stop them.
Yeah.
Yeah.
So I love fellow internists coming up here because I'm always a little nervous. I'm like, he's going to give me some technical question that I can't answer. But no, the diuretics, I just believe if you have to have a catheter, what's the point? And so I get rid of them completely. Yeah,
Great.
The fewer medications, the better.
I agree. Okay,
Yeah.
that's great. When I worked with patients with cirrhosis and back in the West Coast, I found that one of the most challenging aspects in their care when having some of these discussions and sort of trying to get them on board with their own care was that motivational aspect. What have you learned over the years that has helped you to move forward with those discussions, to get them engaged in their own chronic disease management? Did you hear that? Controversial.
No, this is really tough. I remember I was in a talk in the States once about pain management. And I asked almost the exact same question to the pain specialist because I was struggling. I'm trying to manage this person's pain. Remember the whole medication thing, and anything I gave didn't work, and all the psychosocial stuff didn't work, and then they didn't do anything. I was so frustrated. And what he said to me is, never work harder than your patient. And it seems strange, but it's very true. Because we're putting in hours and hours, and you're trying to figure out, how can I get them to engage? And if they're not engaged, this is where this is why I went back and did coaching. Because it's all about coaching, it's about SMART goals. And I remember telling someone once, if you don't quit smoking, you're going to die. This was when I was a young, naive internist. Like, you have to quit smoking, you've quit smoking now. But SMART goals are these small, measurable, relevant, timely, achievable goals. And so if you can say to the patient, what part of your care are you interested in? Because these are the coaching, the what, how, tell me. So what part of your care are you interested in? Well, I'm not really. So what part of your illness is impacting you? Well, I can't walk. What part of not walking would you want to look at? Is there any part of that you want to look at? Oh, well, I don't know. I'd love to walk more. Oh, okay. So what? So you can start actually hammering down little tiny pieces and getting them to think about, if there is a tiny piece of their ascites that contributes to the walking, are you interested in seeing if any of these things that we suggest might help your walking? What can you do? What can you do? Well, I don't know. I can take the LASIK. Well, how much LASIK can you take? Tell me about that. So instead of being our agenda, because in medicine, we're very, in internal medicine especially, I'm like, tick, 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 tick. I call it euboxemic. I want them all the numbers to be in the box and they'll look all great. But in coaching, it's about what they can achieve. So I think that's the approach I would do, is what can you achieve? What do you want to do? And if it's only this and I want you to do this, that's okay, because then they get this, oh, I did that, and then they build on the next. So that would be my recommendation. But if they're doing nothing and you can't get them to do even little tiny things over and over, it is a point where you sit down with them and say, I am so invested in you, and I am working so hard for you. What piece of this is an accountability that you can have? Because it's your life, and you don't want this disease to progress, and really listen to them. If they're on the streets, to be honest, it's very tough. Because when you're on the streets, you have none of the Maslow's hierarchy of needs. You don't have food. You don't know where you're going to live. And so I find it very, very difficult to talk to people when they have no food. They're not going to take their medications. They're not even eating. So that's a totally different story, and they need way more supports. But good questions.
I'm going to combine a couple of online questions because they're similar. Which antibiotics do you use for prophylaxis of SBP, and at what dose, and how does it help with symptoms?
That's very interesting. So I usually use cefuroxime for SBP. And, has that changed in the last months? I don't know. So you might have to look that up and see. But it really does help decrease the infection, and it also helps decrease pain. So those are very important things. I don't use it, and this is very important, I do not use the medication if they don't have SBP. So I've seen many times, I've had actually colleagues say, well, my patients are different, they're very sensitive, I'm going to give it to them even though they don't meet the criteria of having SBP. Don't do that, because then they can get resistant organisms, etc. So only use the medication if it's actually part of a guideline of having SBP. That's something that's very, very important to recognize.
Okay. Does large volume paracentesis have the same hemodynamic renal sodium complications in malignant versus non-malignant etiology?
As far as I know, yes. Anyone in the audience know differently? I've never seen any articles to state otherwise, but should. Thinking about it, though, as an internist, like in controversy, if you have an abdomen full of cancer, that's very inflammatory. So I could guess that you could see some differences. It's not been studied. Do you have some?
It depends if it's transudative or exudative. If it's portal hypertension related, then yes.
Mm-hmm.
If it's simply ascites because the malignancy is intra-abdominal and sort of leaking in, but it actually is not affecting the hemodynamics, then no. But a lot of malignancies, when the liver is burdened with malignancy, then it becomes a portal hypertension issue. So then yes, it's the same.
Oh, it's the same.
It's
Yeah, yeah, yeah.
But if it's like metastatic ovarian cancers that are more peritoneal carcinomatosis, that is not the same.
Oh,
So
interesting.
that you can do large volume with that.
And do you have papers on that? Are there papers?
No, yeah,
yeah.
they describe portal versus non.
Oh, yeah. Okay, good. Thank you.
Thank you for mentioning the DOT test. I've got a liver clinic that I run, so I'll be definitely doing that in my clinic. But some of us want to know exactly how you're measuring it. Is it the time to completion, or how well they do it, how straggly it is?
There's no evidence about this, so
What do you,
everyone's going to think that's a bad doctor. So from my perspective, I keep them, I scan them into the chart. I write on them. So even with the ESAS, my ESASs have writing all over it. So the writing and what the struggle was is important so that I remember. I'll write on it that it took the patient 1 minute to get from 1 to 2. And even if it does, I'll be like, oh, let's not do this. So I'll say they only got to 3. So I'll write it on, I'll scan it in, and the lines that are all wrong are very telling. The key is photocopying the same one. That's the key. You have to have the same one. If you have a different one, it's not too useful.
Great. Thank you.
Someone have a difficult case or a patient that they had struggles with? Anyone have any stories about that? What would you have done with my patient that I took care of when I was in medical school who died with hemorrhage? Does anyone have any comments about what they've seen with hemorrhage?
So maybe while people think about that, I'll ask another question. Is it worth starting rifaximin for HE at the end of life, like when we think the prognosis is just in a couple of weeks or less?
I would. It depends on what the patient wants. If the patient is comfort care and doesn't care about being alert, I wouldn't. If they want to be alert and clear up as much of the encephalopathy as they can, I would. So,
What dose do you start?
oh my gosh, I can't remember the dosing. I'm sorry. Anyone? I reserve my brain space for limited things. I remember when I was a student, and I'm going to tell this because I have a few seconds. I saw this internist, and he knew nothing about pheochromocytoma. And I just studied it, and I thought, this guy is a really bad internist. And so my students will ask questions like that. And I'm like, I have no idea. And now I realize, you know, it's so accessible to look up the doses, is I just really don't
I just
remember.
ask my residents.
Yeah. Well, actually, I say, you should look that up and bring that tomorrow to the team and talk to us. But yeah, no, I'm sorry, I don't remember the dose.
no worries. A similar question just on the rifaximin. Do you give it to all patients with hepatic encephalopathy?
Yes, they all should be on it. Yeah, unless they have some contraindication to it. They've had some reaction to it in the past. Any other things? Go ahead. Yeah.
Hey, I'm Joe Dixon from University of Michigan. Thanks for the talk. Question, you mentioned something about patients who are on the transplant list having a lot of anxiety related to being on the transplant list. I'm curious to hear a little bit more about that because that's something I've definitely experienced, patients being really, really kind of hyper-focused on this very, very small likelihood that they're going to get a transplant. Knowing that that's true, that there's a lot of anxiety around that, and really low likelihood of a transplant actually occurring for most of these patients. How much do you focus in on that? How much do you discuss that with patients? What's your approach? Thank you.
It's huge. So my sickest patients, when I was doing, I initially had a chronic illness outpatient practice for about 5 years. I saw all comers from pulmonary, cardiac, liver, renal. The sickest patients were the transplant patients from cirrhosis, and the sickest in all respects. So psychological illness, mental health. And the reason is, this is what they told me, is they sit there on this list unsure if they're going to die or live for how long, because a transplant is curative. You know, they're being told they're going to get this cure, but then you might not. They watch TV and they wait for someone to die. And this is what a lot of them say. I'm waiting to see a young person die and get excited that that might be my liver. And then I feel like a terrible person because I don't want anyone to die. So they're torn, this thing about how do you live and how don't you live, and are you taking and what was meant to be. And so there's psychological angst. And at the same time, so I was saying before, they're waiting to get worse. So they keep coming in and saying, okay, now, if I make myself worse, and they actually have told me this, if I stop taking all my medications, speaking of, you know, maintenance, and my MELD score goes up, I might get my transplant sooner. Maybe I'll do that. So there's all this angst that they go through. And they do get so sick, and then they go in the ICU because they are full code usually. We had a huge discussion about this in the transplant list. They refuse to have anyone have medical-only goals of care. Even though they might die of a heart attack right now on the floor and they don't want to be resuscitated, they still have to be in R1 because they're on the transplant list. And so that is really distressing for them. So it is so complex. But I'd love to talk later if you have any questions. But it's really, really, they're the sickest. And then often they die, in the ICU even. So very, very complex and hard for the families. Yeah.
In the back, please.
Hi, Jean Zigby, Palliative Care here in Montreal. I wanted to just pick your brain a little bit about patients with peritoneal drains, and when does frequent small volume drainage become large volume drainage? And so I know that you mentioned that giving albumin after 5 liters of drainage at one time is something which you would consider potentially beneficial in order to maintain their blood pressure and whatnot. But what if you're taking off 2 liters, day after day? Is that, or do we have any way of translating that, or is that not really something that we worry about?
Well, we don't know. So first of all, there's no trials on it. However, we tend to say daily. I'll go up to twice a day, small volume, like even a liter and a liter, or 2 liters and 2 liters, 12 hours apart, but I wouldn't go closer than that. I would go 500, 500, 500, depending on their symptoms, what they can take the symptoms off. So we don't really have evidence, but if I was doing, when you get close to 5 liters, you really have to think about albumin replacement. So I'm way down in 1 liter. 1 liter twice a day, 1 liter, 2 liters max. I wouldn't do it more than daily. Let me see. I wouldn't do more than 2 liters twice a day, like 12 hours apart, before I would start worrying about it, because that's 4 liters. But there is no evidence. And I'll tell patients that. So I tell them the smallest volume to take away your symptoms. We'll do an ESAS. Do your symptom before you take it off and after. Do it with the 1 liter. Then do it with the 2 liter. So I really engage them in that, so they actually have some data, if they're willing to do it, or the palliative doc or whoever is with them, actually get something more objective to tell you what the pain is, so you can get it almost like a minimal effective dose for medications. But you don't have an answer, which is hard.
No, I understand, but like 1 liter, 2 liters each day over, a week, 2 weeks.
I'd do that no problem. I'd have no worries even about doing, usually you don't need 2 liters, so I'd have no problem doing 1 liter, 2 liters a day for however long. Yeah, I haven't run into too many issues.
Thank you.
Yeah.
Go ahead in the front.
Hi, it's Raphael from Ottawa. I just wanted to ask about evidence for diuretics in ascites in cancer, because sometimes there might be evidence on imaging that there's portal hypertensive disease. Maybe there's a big clot in the portal vein, or maybe the liver is very, very full of mets and all. Is there any evidence? Because the dogma is don't use diuretics in people with cancer and ascites. Thank you.
I haven't looked up the recent evidence. I don't know if Mino knows, but I haven't looked up the recent evidence. But if you're end of life and you have a belly full of ascites and it's malignant, would I try it? Maybe. I've had minimal success with diuretics. Anyone in the audience who sees more, I see mostly non-cancer patients, so yeah.
There's small studies that have looked at if you do a SAG-directed approach to malignant ascites, and depending on the SAG, decide on diuretic treatments are going directly to large volume paracentesis.
So if it's low, then you'll do the large volume paracentesis. Yeah, that's good to know.
Go ahead.
Hello there. My name's Grace Formels, and I'm a palliative care physician in Ottawa. I also run the hepatology clinic there with one of my colleagues. We're just building it
Awesome.
up. We're very excited.
Ooh,
I was
awesome.
so excited to see your presentation about the alpha pump. I actually care for a patient who's on a trial for alpha pump in Ottawa, so we do have a clinical trial running
Oh, wow.
currently with our hepatologist. My question for you today is about your structure for your small volume paracenteses. We're trying to build some sort of structure in Ottawa for this and have been minimally successful so far. So I'm wondering, who does your small volume paracenteses? Do they have drains in for the non-malignant patients? And are they at home? Are they in hospital? Like, how are you structuring this? Briefly.
They're at home,
Okay.
and it's very difficult. So they have the drains, they're at home, and they do it themselves.
Okay.
So because it's small volume, it's more frequent. Home care usually doesn't want to get involved at all in it. Yeah, and that's a bit of an issue. But we teach the patient or we teach the family, and they do it. And that's the only way we've gotten around it. Like the home care will look at the tubes for us,
Yeah.
make sure they don't look infected, etc. And then if they have problems, they'll go back to the hepatologist or have them replaced. But basically, patient education.
And you've been successful at getting drains in non-malignant patients early enough to do this.
Yeah,
Fabulous. I'll
Yeah.
find you later.
yeah.
Thank you.
Yeah, come find me.
Go ahead, and then we're going to do a couple of online ones.
Hello, my name is Oli Zakri, and I'm a clinical pharmacist from Royal Prince Alfred Hospital in Australia. First, I would like to thank you for your fantastic talk. Thank you very much. My question to you is about the use of opioids in cirrhosis, because unfortunately, as you know, many cirrhosis patients are on large doses of opioids, and you've just brought to the attention of the audience the harms of opioids. How can we go about that? It's very frustrating.
Number one, I love pharmacists. So just telling you, I have a pharmacist on speed dial, both in the US, who's on palliative medicine I met years ago, and also at my home. So your pharmacist is your best resource. I'm just going to give you a little plug there.
Thank you.
Very, very important, though, that we work closely with you. So opioids, when I first started my clinic, I am so careful with opioids. In fact, one of my best colleagues, he's the head of pain medicine at the University of Alberta, and every time I walk by him, he's like, Brisebois, you're still causing addiction in all your patients? And he's laughing because I give 0.2 of hydromorphone. So he thinks it's hilarious because he would never use such low doses. So he thinks it's funny. However, even those small doses, because I use them fairly frequently for pain and cirrhosis patients, I felt they were fairly innocuous to, make myself sound bad, but I really thought it was good. I really had minimal success with using opioids, and now there is evidence that there's increased mortality using them in cirrhosis patients. I really try not to use any opioids. And if they're really dyspneic, so the dyspnea, sometimes I'm more predisposed than the pain, but the management of dyspnea is really getting the fluid down for cirrhosis patients. So I tend to avoid them now. I really try to stay away from medications completely for pain, but it is tough, just like with pain clinics. It takes a lot of resource. You need to have speed dial, psychologists and pain clinics, etc. So if they're really struggling, I try to get them into a pain clinic, but I do understand all the struggles there too. But yeah.
Thank you.
Yeah.
So we'll do an online question and then we'll get back to our floor. Can you explain how you exclude hepatic encephalopathy in patients with cirrhosis and altered mental status? And if the encephalopathy is diagnosed and symptoms persist despite lactulose and rifaximin, do you have any other medications up your sleeve?
I exclude it with an ammonia level. So if the ammonia level is rock solid normal, it would be very unlikely to be hepatic encephalopathy. Are there other medications if those don't work? Something else, in my internal medicine brain saying something else is going on. Because as a slide showed, there's 78% of people have something that's triggering it. So I'm going to look very, very carefully for infection somewhere. Because usually there's something I've missed. So that's the big answer. If I can't fix it, there's something I've missed. If there's nothing and it's just terrible disease and they're dying, then I would go to normal, other anxiolytics, depending on the patient's history. It's very important to think about what their history is, etc. It's one of the only times that I'll use a benzo preferentially. If they have a history of alcohol withdrawal, sometimes the benzodiazepines work very well for those patients. So that's not a bad one, but you can also make the encephalopathy worse. So it's this real balance of what you use. Yeah. So really the same standard palliative care approaches for anxiety they would use.
Thanks in the back, please.
Hey, I'm Ronnie. I'm a palliative care physician in Ottawa. I just had a question about clarification for the antibiotic prophylaxis for SBP, because during the talk, I thought you said that we should use antibiotics if they have low albumin, less than 15, or a history of GI bleed. But then afterwards, you said only give the antibiotics if they have pain or symptoms of SBP. So do we do it?
That's a prophylactic antibiotic. No, if they've, okay, I'm getting confused. If they've already had an episode of SBP, then you will use it as prophylactic.
Ongoing.
Ongoing. Yeah. If they've never had an episode, no.
Okay, perfect. Thank you.
Okay, sorry about that. Yeah.
Go ahead, Roger.
Hi, Roger Gauche, palliative care physician here in Montreal. Over the years, I've had a lot of complicated sort of pain situations in palliative care. When I was in Toronto at Toronto Western, there's a big hepatology center there. My experience with hydromorphone has almost been universally bad. Even at, I remember a case in Toronto, even at 0.25 milligrams PO, the lady was myoclonic after 3 doses. And I remember a review in 2007 was suggesting that actually morphine half-life doesn't increase much in liver, even child's PUC. So I wondered, your experience with morphine versus hydromorphone. And then secondly, if they're hepatorenal, obviously then morphine is not a great option either. And I've had good experience with fentanyl and methadone, and so wondered if you've had that. In fact, just recently, a liver, end-stage liver patient wasn't tolerating hydromorphone and was tolerating methadone very well. Even though they were opioid naive, starting the methadone.
Lots of comments on that. So when we created that website, we had massive debate about this because I believe you can use any of them at the right dose. So if you want to pick morphine 1 milligram or whatever it may be, the patient may do much better on that than the hydromorphone. Our pain specialists were adamant. And in fact, looking at how the drugs are metabolized in the literature, and this is why I was saying the guidelines are fine, but it doesn't take into account, they took morphine off because of that. So I believe personally that morphine is just as good. I've had great success with it, using it at small doses. I'm not sure it's any better. In Australia, hydromorphone's the devil, and oxycodone is the drug of choice. And here we don't have, so I think they're all fine is my answer. And as long as you know, okay, they're metabolized similarly, one might be better, one might be worse, one might use smaller. Methadone, excellent, absolutely. I've had great success with methadone. We use it quite a bit on the palliative care unit in Edmonton, and it's good medication. You have to have someone that's comfortable using it. So is it someone in the community, whoever it is, as long as they're comfortable, yes, that's an excellent option, but it's just harder to maintain. And then the fentanyl, again, harder to administer. I'm not a big fan of patches because I can't titrate them so much. So I don't tend to use patches, but I wouldn't say it was wrong. I use lots of sublingual fentanyl for dyspnea in COPD patients. So I think the answer is whatever you find is working is right. You're having trouble with hydromorphone because the doses are too high. That's what I was saying about the guidelines. Oh, yeah, great, give your patient 0.5. I'm like, okay, because we had big arguments about this because I wanted it to be lower. And they ended up just saying, well, pay attention to your patient. If they're not doing well, drop it. Whereas I tend to try to start lower. So it shows you the difficulties making guidelines and what you guys will be seeing. Yeah.
Thank you. And the second question would be about antipsychotics. So with hepatic encephalopathy patients in a palliative context where it's not getting better, I've had some success with them in terms of reducing some hallucinations or just giving a bit more time in the day where they're coherent. I wondered what I don't think it was mentioned. So
No, it wasn't. And in fact, that other question touched upon that. And then after they left, I thought about it. All of the medications, you really have to pay attention to the pharmacodynamics of the antipsychotics, but Remeron is quite good. And so I like Remeron, a small dose at night. It actually allows some mood stabilization, can increase their appetite. So it's a very good one for cirrhosis, and I do tend to use that one first. I haven't had great success, to be honest, with others, but I will try others. Remeron would be my first bet. Yeah. I don't know if anyone else has used a lot of antipsychotics, but...
Mirtazapine, for those of you who might
Oh, yes,
have-
sorry to use a trade name. Shouldn't have done that. Mirtazapine, bad on me. Okay, don't evaluate me poorly because of that. Thank you.
On that note, we are out of time.
Too late.
Yeah, that was fabulous. Thanks so much, Mandy.
I love it. That's so funny.
And we'll get back to you, all of you who are asking questions about the slides. We're going to start right at 1 with our afternoon session, so please try to arrive a few minutes early and again move into the middle so we can fit everybody in. Enjoy your lunch. Thanks.
And thank you, everyone, for being here. I'd love to talk to you after if you ever see me wandering around. And where'd Olivia go? Olivia, don't leave. Okay.
Thank you.